I'm going to start introduction of Professor Elsayes, and Dr. Serlin will add more information. So just as a background, Dr. Elsayes is a professor of radiology at University of Texas MD Anderson Cancer Center. He's a very well-known, world-renowned radiologist specializing in liver imaging. He has numerous peer-review publications and abstract, more than 200. He has over 100 visiting professorship. He has 85 international awards. He's an eminent speaker and just an outstanding educator. And he's just a superb driving force of disseminating knowledge, particularly about LI-RADS. And he organized this just outstanding lecture series within just a few days. And literally, he's the only person who's capable of doing such an amazing job so quickly. So with that, Dr. Serlin.
Thank you, Dr. Cherniak. I just wanted to add one other thing about Professor Elsayes, which is that he is unbelievably generous and humble, and he's always interested in helping his colleagues, his friends, and his students, even when he receives no credit. And just to illustrate that, a couple years ago, he organized a series of exhibits at the RSNA on LI-RADS. I think there were about 10 exhibits or so that he organized, and he was able to get junior faculty and students to be involved in every single one of them. And he did a tremendous amount of work, but he was not actually an author on any single one of them. So even though he did more work than anyone else, if you were to look at his curriculum vitae, none of those things are in there because he did it all to help his students and his friends and his colleagues. So with that, I'll turn it over to Professor Elsayes, who truly is the embodiment, I think, of generosity in academics. So Professor Elsayes.
Thank you very, very much, Dr. Serlin and Dr. Cherniak. This is really, really very kind of you, and not unexpected to hear these kind words and nice words from both of you. You're always nice and kind, and you know, just say good words. I don't think they are real, but you know, they are appreciated. Thank you very much for this kind and generous introduction. You know how much I love both of you, and I love my LI-RADS team. So when you love people, people love you, and which is really a blessing. So I'm going to start about talking about pitfalls in imaging of cirrhosis and user errors in applying LI-RADS. And I have no financial disclosure. What I will do is I will actually go over the LI-RADS algorithm and tell you exactly where I think the problems will happen, and when people feel that LI-RADS doesn't work, you know, while they are the ones who are making probably mistakes and errors in applying LI-RADS. And so the first thing, this is 36-year-old woman with chronic Budd-Chiari syndrome. So we apply LI-RADS here, and this is, so there is a hyper-enhancing observation. So you're applying LI-RADS, it measures, maybe let's say that it measures more than 2 centimeters, so it will be LR4, so it's probably HCC. And someone would actually handle the case like that while didn't look at the history and presentation of this patient, which is chronic Budd-Chiari syndrome. And this actually mistakes that can happen at the reporting, and it was well illustrated and well explained in LI-RADS core. And you know, that's the beauty of LI-RADS, it just defines most terms and defines most things in liver imaging in cirrhotic liver or patients at risk. So LI-RADS here does not apply because it was very well explained in the core curriculum that it applies in certain scenarios, and it does not apply in cirrhosis due to vascular disorders such as hereditary hemorrhagic telangiectasia and Budd-Chiari syndrome and other things too. And what's the clinical relevance? What's the explanation for that? The explanation for that is there can be benign nodules that occur more commonly than hepatocellular carcinoma in such cases, in such conditions. And particularly with Budd-Chiari, you see large regenerative nodules that would be hyper-enhancing, mimicking HCC. So if you apply LI-RADS here, this will lead to an acceptable number of false positive diagnoses, and the LI-RADS team led by Claude and Victoria are eager to keep the high sensitivity and the specificity of definite HCC, which is LR5. So as a reminder, this is when you apply LI-RADS, that's a patient, the target population, which is cirrhosis, chronic hepatitis B, viral infection, or current, and that doesn't need cirrhosis actually to apply LI-RADS, the hepatitis B, current or prior history of HCC. I would not cover the whole thing because it has been covered before, but it's a very important reminder for all of us to look into the target population and apply it properly rather than applying it in every patients, in every cirrhotic patient, such in this case with chronic Budd-Chiari, where the benign regenerative nodules would be a lot more common than hepatocellular carcinoma, and applying LI-RADS will lead to an acceptable high number of false positive. As a reminder, this is the carcinogenesis, which also was covered in prior lectures, and we'll probably get even a pathologist who will talk about it and will provide nice radiology correlation in the next series. And that's how we go over the observation. You guys remember this? Victoria and the team has gone, and Claude and the team has gone over that in the prior lectures. So that's how we start, right? I'm reminding you that of the LI-RADS algorithm and table, and that's how we start, non-categorizable. Then you exclude TIV, LR-TIV, tumor in vein, LR1, LR2, then LRM. And if it does not apply to any of that, then you will start applying the algorithm. So this is a case of a 70 or 45-year-old man with a history of alcoholic cirrhosis, and it came for evaluation of a suspicious mass. And someone read this as a cholangiocarcinoma because it demonstrates capsular retraction, it demonstrates an enhancement, but this enhancement actually progressively increases over time to retain contrast over the delayed phase, and that's how it was actually interpreted as cholangiocarcinoma in this case, which would be, I mean, the question here, then this would be LRM or what? So one of the most important thing about these pitfalls is knowing them. Funding, just funding the knowledge of radiology knowledge would help you in avoiding a lot of these errors. And that has actually a characteristic look and the characteristic features that would be enough to diagnose confluent hepatic fibrosis. And confluent hepatic fibrosis is well defined in LI-RADS as LR1 if you're sure that this is confluent hepatic fibrosis, or LR2 if you are not sure that it's confluent hepatic fibrosis, but you really think it's confluent hepatic fibrosis. Would be LR1, which is definitely benign, or LR2, which is probably benign. So knowing this entity would actually help you avoid the misdiagnosis of LRM or probably cholangiocarcinoma in such case. So this case can be confused with cholangiocarcinoma, treated malignancies, or epithelioid hemangioendothelioma. So anything that would have an element of fibrosis that will lead to capsular retraction and also will lead to early on hypoenhancement. And this case actually was hyper-enhancing in the arterial phase, which is not very usual for confluent hepatic fibrosis, but has been also reported. So anything that would lead to volume loss and capsular retraction could be actually confused with confluent hepatic fibrosis, and these are some malignancies that could be misinterpreted for this entity. How would you know that this is confluent hepatic fibrosis? First of all, characteristic location, medial segment of left hepatic lobe and the anterior segment of right hepatic lobe, which are segments 4, 5, and 8 in particular, and wedge-shaped appearance, volume loss, and you can see associated crowding of vessels. It's usually hypo-enhancing in the arterial phase, but progressively enhanced on the delayed phase. Arterial enhancement is rare in such conditions. Another case here, which is again demonstrated in a cirrhotic liver, and you can see faint peripheral enhancement, almost a rim enhancement, and this would be reasonable to characterize it as LRM. But looking up the previous imaging here in 2 years ago, demonstrated peripheral nodular discontinuous enhancement in this mass, which is characteristic for hemangioma. So it's very important for us to know that hemangioma, first of all, hemangioma and other benign lesions are less common in patients with cirrhosis. And the other thing is, so hemangioma are commonly encountered in cirrhotic liver. The other thing is that the advancing fibrosis and morphologic evolution in cirrhosis changes the morphology of hemangioma, like what we see here in such case that could actually be misinterpreted as LRM. And checking previous examination is very important in radiology in general, in imaging in general, but in particular in liver imaging is very, very important to look at the evolution of the pathologies and the observations in cirrhosis. And that's why also threshold growth is one of the major features. So if you have previous imaging, that would be of paramount significance in evaluation of observations in cirrhotic liver. So those are things that could be actually misinterpreted for LRM, and knowing about them could help you avoid this misinterpretation. And then after that, we excluded all of these categories. Then we're going to go for looking at the major features. And the first major features we look at is the size. And very important for us to remember that you measure the observation from the outer edge to outer edge. And the size more, 10 millimeter or more is required for LR5. And look at this observation here. So this is a woman with cirrhosis due to chronic hepatitis C. So we'll apply LI-RADS here. And then we have an observation. This observation measure 15 millimeter. So you put it together in the LI-RADS table, an algorithm table, and you start applying it. And based on the most recent version, this will be LR5, right? Because it shows arterial phase hyperenhancement and washout, right? So, but there is a very important error that we made here. This error was in accurate measurement, because if you don't follow LI-RADS and the specifics of LI-RADS, then this is when you can actually start making errors. When you measure it later on in the portovenous phase, they measured 8 millimeter, and will completely change the category here from LR5 to LR4 based on the different measurement. So it's very important for us to remember when you obtain, or where and how you obtain the measurement of the observation in liver cirrhosis. Very important for us to know that you avoid obtaining the measurement in the arterial phase. If we go back to the previous slide, we measured it here, and you can easily tell that this measurement will be overestimating the observation by just visually comparing between the observation in the arterial phase and the portovenous phase, and also the delayed phase. So number one is you actually don't measure it in the arterial phase or diffusion weighted images if the margins are clearly visible on different phase. So if the margins are clearly visible in the portovenous and delayed phase, that's when the observations are well circumscribed, you can really obtain the measurement. You avoid any observational enhancement, like when we come later for other feature, we're going to describe what exactly this means. But very important, again, it's very important reminder is that you measure it where the lesion or where the observation is most conspicuous and most clearly depicted, and that's not the arterial phase, that's usually the portovenous and the delayed phase. You also you include the capsule with you, so the capsule is not seen in the arterial phase, the capsule would be seen in the portovenous and delayed phase. So you include the capsule with you in the measurement, and you measure the largest outer to outer edge. So all of these all of these definitions are very important. All of these characteristics for accurate size are very important for obtaining an accurate size, and don't overestimate the size of the observation. So it's very important. Those are very important reminders, very important technical details for obtaining the size, which is outer to outer edge size is 10 millimeter or more is required for LR5, and don't use arterial phase and diffusion weighted imaging. What's the second, and also again most important, I would say, the major feature is arterial phase hyperenhancement. And I'm giving an example here. So what do you guys think? This is HCC or not HCC? And I'm showing you the arterial phase and the T2. So in the arterial phase, I give it a second to you to think about it. Is this enhancing or not enhancing? I would say that this is definitely enhancing. But the question here is not really the enhancement, because the liver itself enhances, the normal liver enhances, the surrounding liver enhances. It's about hyper enhancement, right? And that's again the beauty of the terms of LI-RADS. When you talk about an observation in the arterial phase, and you talk about the major feature of arterial phase hyperenhancement, it's clearly defined as hyperenhancement, not just an enhancement, not just iso enhancing. And you can prove that when you have MRI. When you do MRI, you can prove that by subtraction. So when you do subtraction here, you don't see enhancement more than the liver parenchyma. So the question is not just enhancing, but the question whether this observation is hyper enhancing. This was actually pathologically proven. This was biopsied and was proven to represent macro regenerative nodules. We actually are used to see the regenerative nodules small in size, but rarely they can grow in size and reach larger size like what we see here, and that can mimic hepatocellular carcinoma. So going back again to the definition of non-REM arterial phase hyperenhancement, this is unequivocally. So if you're even having doubts that this is greater in whole or apart than the liver, then this would not be arterial phase hyperenhancing observation. So that's a very important term here, which is hyperenhancing observation. The other thing here, we're going again to the arterial phase, and we see an observation here. And we have actually talked about the requirement for this to be LR5. So can this be LR5 based on, so raise your hand. I don't want you to speak. I want you to mute yourself, but just ask yourself this question: can this be LR5 or not? And the answer will be no, it won't. Most of the answer based on giving this question to my trainees in the best. No, it won't be LR5 based on my own teaching, based on Dr. Serlin's teaching, based on Dr. Cherniak teaching, that it has to be arterial phase hyperenhancing to be defined or to be categorized as LR5. However, actually, this was an error in our answer, because that's not a late arterial phase. Okay, so this is the late arterial phase, and you see the same observation enhancing. Okay, so this is arterial phase hyper enhancing that was actually misinterpreted as hypoenhancing in the early arterial phase. So how would you know that this is the proper late arterial phase? So look at the portal vein, and that's when you should see an early enhancement of the portal vein. That's the late arterial phase, and that's how you define the late arterial phase and distinguish it from the early arterial phase, and that's surely defined in the core. So I actually invite all of you to go to the core document, and you see it defined that this is it has to be late arterial phase. A late arterial phase is a subtype of arterial phase in which the portal vein is enhanced, like what I showed in the previous example. Another example here of this is late arterial enhancement. So the trick is not in this case anymore. So what would you think? This is an arterial phase hyperenhancement or not? I see definitely unequivocally higher in attenuation than the surrounding cirrhotic liver. So this would be arterial phase hyperenhancing, yes or not? Actually, the problem with this case is this is the CT, and in the pre-contrast, we looked at the pre-contrast, and the pre-contrast was already hyperdense in the pre-contrast. So this was a sidrotic regenerative nodule. So make sure it's enhancing, not just hyperdense lesion, because not every hyperdense lesion is enhancing. And this case, actually, I give this the courtesy of Dr. Berry and Dr. Brancatelli that shows sidrotic regenerative nodules. Basically, sidrotic is what? It contains iron, and iron would actually look hyperdense in the CT, in the pre-contrast CT. But here, you put the attenuation, it does not enhance on both observations in the pre and post contrast, and you find out that it does not really enhance. It is just hyper dense rather than hyper enhancing, and that's a characteristic for sidrotic regenerative nodule that would be misinterpreted as hyper enhancing observation. And I'm just mentioning examples because in most of our practices where we read a lot of cases, we can easily overlook the pre-contrast if it's there, actually, because a lot of institutions are not using the pre-contrast, not even recommended, but based on LI-RADS technical recommendation. But if it's present, then you actually should look for it and should actually confirm that this is hyper enhancing or not, or just hyperdense. Another example here, by MRI, we see an observation that is unequivocally higher in intensity in the arterial phase than the surrounding liver. But we looked at, again, the pre-contrast. It is already hyper intense. The solution here is to do subtraction, and with subtraction, you would see that this is not really enhancing more than the surrounding liver. And again, this would represent sidrotic, dysplastic nodule. This is dysplastic nodule rather than HCC. So again, we have to be very careful in the definition. When we define something as arterial phase hyperenhancement, we need to make sure that is really a hyper-enhancing observation, and this can be confirmed by subtraction on MR. Another observation here that is demonstrated on the arterial phase as hyper, it looks like apparently hyper-enhancing, but we looked at the pre-contrast T1, and in the pre-contrast T1, this observation is significantly really hyper intense. So how would you solve this? Again, you look at the subtraction, and with subtraction it shows an enhancement. So this would be an arterial phase hyper enhancement. So the pre-contrast T1 hyper intense could be either dysplastic nodule or HCC, and not just a dysplastic nodule. And you solve this by looking at the subtraction and making sure that is hyper enhancing or not hyper enhancing. So this is these are some of the errors that could be made with arterial phase hyper enhancing observation and for the definition. So you need to define it based on the late arterial phase, not the early arterial phase. You need also to make sure that is really hyper enhancing, not just hyper intense or hyper dense, and also hyper intense on MR or hyper dense on CT. Another thing about hyper enhancement here, an observation like that. And what we notice in this observation, most of us will measure this observation from here, outer edge to outer edge, if we have a portovenous and delayed phase, of course. But in the arterial phase, you can't really tell between the two observations here. Those are not one observations, they are two observations, or one observation mainly here, which is this hypoechoic nodule or hypoechoic observation that does demonstrate arterial phase hyperenhancement, but you also see surrounding aliasing on ultrasound, color Doppler ultrasound, and you see serpiginous enhancement at the margin of this observation. So what happened here is, occasionally you see this transitumoral shunt, AB shunt, and what's really interesting in this case here is you see early enhancement of the portal vein due to this arteriovenous communication, and so we need to be aware of that, and because it's very important. Two things are very important here. Number one, and we know how important now is the size and not overestimating the size. Also, it's very important not to overestimate the number, because that can be potential pitfall of measurement of the entire observation here, the two observations, which would significantly overestimate the size of the observation, or considering these as two discrete observations. That's another pitfall that we can make here in this case. And knowledge of this entity would be very important for us to avoid that error. And what's AB shunt? AB shunt can be seen in association with tumors, and not just malignant tumors, but can be also seen association with benign tumors such as hemangioma, for example. In this particular case, there was a very nice clue, which is a portal vein showing early enhancement, but there was also a very nice illustration of the aliasing of this shunt adjacent to the focus of HCC. So this is a reminder for us again for the arterial phase hyperenhancement and the problems that can occur with arterial phase hyperenhancement. I didn't demonstrate the other things, but the very important lesson from the previous case is not every arterial phase hyperenhancing observation is a solid tumor. Not every arterial phase hyperenhancing observation is HCC. It could be just vascular phenomena as well. And I'm going to the third major feature, which is the washout, and it's defined as non-peripheral washout. I'm showing a case here where you see an observation in the arterial phase, which is arterial phase hyperenhancing, and you see washout later on. Okay, so it's 11 millimeter, and based on the version 2018, the washout as one major feature, in addition to the arterial phase hyperenhancement in an observation that is measuring 10 millimeter or above, is sufficient to categorize this observation as definite HCC LR5. However, in this particular case, so based on this table, you reach LR4, LR5, and this was washout, so it would be LR5, right? Many of us would categorize this as like that. However, there is a very important lesson here, which is what type of contrast agent used in this particular case. First of all, this is a transitional phase, not just a delayed phase that would be seen with extracellular and also extracellular contrast agent. So this is a transitional phase that is obtained after injection of EUVEST in America, or Primovest overseas, like hepatobiliary contrast agent. And it's very important and very also well defined in LI-RADS what exactly you use for washout, what phase you use to define the washout. And here, so number one, as we said, it's non-peripheral, and I'll tell you why non-peripheral. But it's very important here to remind you that you use the portovenous phase and delayed phase if extracellular contrast agent like gadobenate is given, or gadobenate is given, right? But use only the portovenous phase if gadoxetate, which is EOVEST here in America, which is Primovest overseas, is given. And in such a case, here there was EOVEST given, so gadoxetate given, and this was a transitional phase, so you can't count on it for defining the washout. Another case here, this patient was also a patient at risk of hepatocellular carcinoma. And in a busy day, you look at the arterial phase here, and which is correctly obtained as late arterial phase, and you don't see any observation. And many of us would dismiss the case like that. However, there is a clear washout or clear hypodensity in the delayed phase noted in such a case. And this hypointensity, many of us would think that this is not washout because it was not demonstrating arterial phase hyperenhancement. However, this is another pitfall. So number one pitfall is not detecting this, because in a busy day you may overlook the delayed phase. But the second lesson, which is really a common misunderstanding, that the arterial phase hyperenhancement is required to characterize washout. However, arterial phase hyperenhancement is not required to characterize washout. You can actually call washout even without presence of arterial phase hyperenhancement, such as in this case again. And this can be seen in a minority of HCC and can be explained by the hepatocarcinogenesis, as early HCC may lose portal venous supply before developing sufficient arterial new vascularity to be visible in the arterial phase. So they lose the portal venous supply first, which can lead to this washout appearance in the portovenous and the delayed phase, but did not yet develop sufficient arterial new vascularity to be visible in the arterial phase. That could be the explanation for seeing washout without arterial phase hyperenhancement. So it should be, as we said, non-peripheral washout. Very important to define the phase where you can actually depict washout, which is only portal venous phase in hepatobiliary contrast agent, okay, and portal venous phase and the delayed phase on extracellular contrast agent. And again, the second lesson is arterial phase hyperenhancement is not needed to call washout. The fourth major feature is enhancing capsule. You look at this observation here in a patient also in a target population of high risk for development of HCC, and there is an arterial phase that is definitely arterial phase hyper-enhancing observation, right? And you see something like peripheral enhancement in the periphery here. Some of us would call this enhancing capsule, which would be wrong because this is how enhancing capsule should look like. Well, I'm actually giving this as a comparison to what we see with this appearance. This appearance is a corona enhancement. And by looking at them, if rim enhancement increases, if the peripheral enhancement, and I don't want to mix this with rim enhancement for LRM, but if rim enhancement increases in portovenous, delayed phase, and transitional phase, then this would be an enhancing capsule. If it is shown in the late arterial phase and portal venous phase then fades, then this would be characteristic for corona enhancement. The other thing is the enhancing capsule is a smooth, sharp, and uniform, forming the edge of the observation, but corona enhancement are perfusional phenomena, not discrete structure. It could be thick, it tends to be centric, usually less well-defined than the enhancing capsule, and extends beyond the observation edge. So this is again another error that could be made. It's not a huge error though, because corona enhancement is one of the ancillary features for malignancy. So capsule appearance and awareness and knowledge of the capsule appearance is very important, and that it's very important not to misinterpret the corona enhancement for capsule enhancement or enhancing capsule, and those are together are very important lessons. Now I've gone over many lessons here with the major features and errors, but there can be unavoidable misses or unavoidable errors, like this case, which is very rare, and it shows what? It shows an arterial phase hyperenhancement, but then this observation follows the blood pool. Okay, and in an observation like that, that has not been or is not typical appearance for hepatocellular carcinoma to see that, because typical appearance is to see enhancing, washout and enhancing capsule later on. That is very rare incidence of HSCC, very rare appearance of HSCC, but the beauty of LI-RADS is you follow LI-RADS category here, categorization, and this will be probably LR4, which is probably HSCC, would be still demonstrating suspicious features that will be enough to call this LR4, and the probable management for this observation would be biopsy, and this was biopsied and found to be HSCC with biliotic changes exhibiting enhancement in the delayed phase. Again, that is very rare incidence in patients with HSCC, and this biliotic changes is what lead to the blood pool enhancement, which is retention of enhancement or keeping enhancement or enhancement, similar to the vasculature in all phases, like what we see here. But the solution here would be, if you still follow LI-RADS, and this is the beauty of LI-RADS, if you read this on your own, then you may actually really doubt, and you may not be sure that this is HSCC, right? But if you follow LI-RAD, you will say that this is probably following the categorization and following the table and the algorithm. This will be LR4 and will probably be HSCC and will probably be biopsied. So this is an overview of what we have covered. The only thing that for the major features that we did not cover is the threshold growth, because I think that also the errors for threshold growth would be also compatible with the errors for obtaining the size, because the threshold growth, you may the errors here may be obtaining in different fashion of the previous image, which is also defined in threshold growth, is you actually should obtain the size and compare it to a comparable appearance at comparable level, like same plane, same phase of the previous imaging, and also maybe errors also that you using the arterial phase or the diffusion weighted imaging that could lead to errors in obtaining measurement and errors in defining threshold growth. And with that, I would remind you with what's left in applying the algorithm for LI-RADS. You apply the ancillary features, tie-breaking rules, and final check. This was covered by my colleagues in the previous lectures, and it was a pleasure talking to all of you. So thank you very much for listening and attending. And again, we are all inspired by all of you attending from all over the world. And I think my colleagues here can handle the questions. Thank you very much.
Thank you. That was me. That was Claude. Thank you, Professor Elsayes, for that outstanding and very educational and informative lecture.